Hi, my name is Patrik Hutzel from intensivecareathome.com, where we provide tailor-made solutions for long-term ventilated adults and children with tracheostomies at home. Welcome to another podcast here at intensivecareathome.com, and today I have a very special guest, Kristi Gilbert. Kristi Gilbert is a CCRN, a critical care nurse by background, but also a legal nurse consultant. Kristi, why don't you introduce yourself to our audience, and then we will go into what we want to talk about today.
Thanks, Patrik. Thanks for the introduction. Yeah, I've been nursing for just over 30 years now. It's gone really quickly. Most of that was in intensive care and emergency departments. My career kind of took a bit of a change just before COVID when I got the opportunity to work as a legal nurse consultant. And that side of my nursing has really grown as its own business now. And also COVID kind of promoted a change in my career into community nursing and palliative care. So I've got a grad dip in critical care, and I'm now doing a master's in advanced nursing as a nurse practitioner in palliative care. So it's an interesting space.
Yeah, that's fantastic. And I know with you doing palliative care in the community, you see a lot of the things that we are seeing with intensive care at home. You see the benefits of home care, but you've also observed some of the negatives of home care, and that's also something we want to talk about today. Kristi has done a lot of work for us in the last maybe 18 months, 2 years, with some specialist nursing assessments for our clients, predominantly for our clients on ventilation with tracheostomy, but also for some clients with tracheostomy that are not ventilated, and also for some clients on non-invasive ventilation, BiPAP, CPAP. And it's been great to have you on board, Kristi, with those nursing assessments. They are very, very detailed.
Thanks.
And really gives the NDIS no way out to fund support workers, what can't even be done by a registered nurse, which needs to be done by critical care registered nurses in the community, which is all we do here at Intensive Care at Home. So it's been really great to give us your deep dive of those assessments. We have been doing them for the last 10 years, and they've always gotten the funding for the clients, but yours are so much more detailed because of your legal nurse consultant qualification as well, and your extensive critical care nursing experience. So that's been really great. Now, do you want to talk a little bit more about, we sometimes have clients come to us and they say, hey, we know we need your service, but we don't have the funding. And then I say to them, look, you need an NDIS support coordinator. And then once you've got an NDIS support coordinator, we can help you with a detailed specialist NDIS nursing assessment. Can you talk a little bit about what those assessments look like from your perspective? And I know what they look like, but for our audience, can you explain a little more?
Yeah, so I guess once I get the referral from you, I get a lot of information. I might get other specialist reports, OTs, dietitian, physio, medical specialists. I often meet the client and the family. Sometimes we've had to do that over Zoom calls for one reason or another, but it gives me a sense then of what the home environment's like and what supports they've got in place already, and then what level of care that they need, because you're not only assessing kind of, where they're at right now, but also those reports you're assessing their funding ongoing, so for at least another 12 months. So you're kind of looking at, what's their level of deterioration been, what level of support do they need now, but what will they need likely in the next 12 months to get them, to make sure that they're safe at home. And ultimately that's the goal, is to make sure that the care that they're getting is appropriate and safe to be able to maintain their level of function and to have high quality care at home.
Have high quality care at home and to avoid hospital admissions. That's one thing.
Absolutely.
And I also need to highlight once again, and I mentioned it on many of my other videos, people have died in the community if they didn't have the critical care nurse 24 hours a day for ventilation plus minus tracheostomy. That's how serious this is. So if you are a family member watching this and you have a loved one either at home already with insufficient support, or if you're an NDIS support coordinator watching this, unfortunately, we are not making it up when I say people have died because they didn't have the critical care nurse 24 hours a day at home, or they bounce back to ICU all the time. Either can be avoided with having the critical care nurse funded 24 hours a day. Most of that funding that we are referring to here is NDIS funding. But, you know, there are other examples too, whether it's the TAC in Victoria or in iCare in New South Wales. You know, often the advocacy needs to be done as well for the CCRN, for a ventilated / tracheostomy client. Unfortunately, the consequences are so grave if you don't get the right support, and it might be fine 364 days of the year, but it's that one day where the tracheostomy comes out, or where there is an airway management issue that a support worker or even a general registered nurse can't manage, where a client can die. That's how severe or significant it is, what we're talking about here today.
I think that's a really important point you make, Patrik, is that in a hospital setting, it's predominantly ICU nurses who are looking after people with tracheostomies and ventilators, especially if they're ventilated. Certainly a general RN can look after most tracheostomies, depending on the level of support that they need. But they're in an environment that's very well supported, and you're talking about people who are at home with no backup and no support. And a general RN would feel very unsupported even in a hospital looking after a ventilated client. And I think that's a distinction that has to be made, is that when you're looking at caring for someone with really high needs at home, that you have to have that level of education and training and experience to not just be able to do the day-to-day things, but to recognise when things are going wrong and then to intervene so that you're not relying on an ambulance that might take an hour.
And we've talked about this extensively offline, Kristi, that even if the ambulance arrives after maybe an hour, there's no guarantee they know what to do with a ventilator or a tracheostomy. Yep. We've seen that in real time now, that yes, you might get an ambulance, you might even get an ambulance within 10 or 20 minutes, but there's absolutely no guarantee that they know what to do with a ventilator or an unstable airway in general.
Yep. Unless you're getting a mica, it's pretty unlikely. And, you know,
right.
Yep. It's very tricky, and I think that's why it's so important to have the right level of care in the home.
Right from the start. And one thing that I can confidently say here, you know, and I've been saying it on other videos too, I can confidently say that our clients stay at home predictably, right? Because, you know, we wouldn't be in business if our clients were going back to hospital all the time. You know, it is also from a family perspective. You want your family member home predictably. You just don't want it.
That's right.
You know, you don't want your family member go back to hospital all the time. And I think the other thing that's important here, Kristi, and I know you are, the palliative care that you are doing is also, it's not metro, it's sort of on the fringes.
Regional, yeah.
Regional, thank you. You know, especially if you are regional, and especially if you're sort of in the higher acuity sphere in the community, well, you certainly don't want to go to hospital, you know, and there could be even a bigger delay in regional areas to get an ambulance. That's
absolutely. Yep, absolutely, especially overnight.
Yeah, and
which is sadly when a lot of things seem to go wrong.
Yeah, absolutely. No, thank you for sharing that. Now, Kristi, another thing with the work that you are doing and with the work that we are doing, obviously something that we have come across in the last few years is the NDIS wanting to implement what they refer to as a delegated model of care, where they pretty much ask us as registered nurses or critical care registered nurses to teach support workers how to look after someone on a ventilator with a tracheostomy, or look after a tracheostomy without a ventilator. Now, you and I cringe, and many other nurses in this space cringe when we hear that. And there's a number of issues with that. And where do I even start? The first issue that comes to mind is, well, if we can train support workers to basically do CCRN work, why are our intensive care units not staffed by support workers? That's the first question that comes to mind. But the bigger issue here is, where do nurses stand with that delegated model of care in terms of our responsibility in terms of hourly liability. My take on it, if I teach a support worker what to do with a ventilator and a tracheostomy, they don't have all the background, the general nursing care, the anatomy, the physiology, none of that. I just show them how to basically try and keep someone alive with all the other knowledge that you need to have to underpin that. Well, that's the first thing. But the next thing is, if I teach them and something goes wrong, I really can't take that responsibility for it. And on top of that, APRA doesn't allow us, the regulator body, to allow us to delegate care. Where do we stand with all of that, Kristi? I know you've done a lot of groundwork there. Can you share more?
I think it's really important that nurses who are working in the disability space have a really clear understanding of what APRA's requirement is for delegation. And they're very clear on what it involves, and that is that you have to make sure that the delegation is safe, that the person that you're delegating to has the appropriate knowledge, skills and experience to be able to carry out that task to the same level that you would with the same outcome. So that's the first part of it. The second part of it is that you can't delegate the accountability. That remains with you. It also remains with the person who's accepting the delegation. So they have to make sure that that's within their own scope of practice as well, based on their knowledge and skills, training, experience. And that you're also responsible for the outcome of that delegation. So, and making sure that you have checked that what was delegated was done correctly and that the desired outcome was achieved. And I think that that's the part that's really important. So you can't delegate away that accountability and say, well, I gave it to them to do, and they said that they were fine to do it, and so therefore my responsibility is now gone. It's not. So the responsibility remains with you. So I think that's part one of it. The second part is that in teaching, you might teach a support worker, but they're a highly transient workforce, which the NDIS has recognised themselves. And so you might teach one, but then that person might have numerous support workers involved in their care. And unless you're teaching all of them and then that base of support workers remains stable, you're constantly retraining people to do the task that you could have just done yourself. And you're not there 24/7. So the RN, it's direct or indirect, but the RN should really be on site to be able to make sure that that delegation is being carried out safely.
Yeah. But that's also not what the NDIS wants. They basically want RNs to run support workers through a crash course.
They do. Yep. So it's basically some online modules which are not comprehensive. And then it's, watching them do the task and then signing them off that they're safe to do it, which is not how delegation works. That's not delegation. So you can't just teach someone to do it with an online module and a little bit of training. What they're asking support workers to do in the community is to perform tasks that it takes an RN who has already got a 3 or 4 year bachelor degree and clinical experience, and then a postgraduate degree in critical care, which is another 12-month, postgraduate certificate or graduate diploma. That's a lot of knowledge and experience to then teach it to someone who doesn't even have a basic degree. It's just a TAFE course. And there's not even actually a legislated requirement for their education like there is for nurses. We have standards that we have to adhere to. We have legislation that guides our practice. Our education is regulated by APRA and the Nurses Board. There's none of that with a support worker. So most agencies will require that they have some kind of TAFE course behind them, but it's not mandated. So, you could get a support worker who's had no training, or you can get a support worker who might have done, a short course in, a Cert 3 or a Cert 4 level. But that's nothing compared to the training and knowledge that a registered nurse has. You just can't compare the two. So it's unfair then to expect that a support worker will be able to perform the same tasks to the same level as a registered nurse or a critical care registered nurse in a lot of the cases where you're talking about patients with trachees and ventilation or even BiPAP.
Yeah. But isn't it interesting what we've also dug out as part of the research is that there was a court case in November 2022 where the federal court basically overruled the NDIS that certain clients within the NDIS need a registered nurse, not a support worker. And that wasn't even in regards to ventilation, tracheostomy. This was in regards to general nursing care. Can you talk more about that?
Yeah, so that was it was 3 NDIS clients with high needs but not high intensity needs who were being cared for in a shared facility. And NDIS basically wanted to have this delegated model of care where the RNs would come in and train up some support workers who would then take over the care, and the nurses would only have some kind of semi-regular input in terms of, I'm not sure exactly what their requirement was, but it was, maybe 6 hours a week or something, where they would do the care planning and just kind of monitor. But the actual day-to-day care was just being provided by support workers with no oversight from RNs. It went through the Administrative Appeals Tribunal, where the Appeals Tribunal found in favour of the clients that they should have registered nurses. NDIS obviously took it to court to appeal, and it was overruled in the federal court that it wasn't safe for those clients to have no day-to-day registered nurse oversight of their care, and that was not safe. That was not inconsistent with their delegation requirements for registered nurses. And that you are looking at a transient population of support workers who you would be constantly training them anyway. And you're not there to make sure that the outcome of the delegation was safe. So they were overruled, and the clients got the registered nurse funding. And
from memory, Kristi, like you've mentioned, it wasn't about ventilation, tracheostomy. This was about catheter care, PEG tube management. I think there was some insulin management as well.
Medication management, which is really, these are things that if you're doing them on a day-to-day basis, how things can change or go wrong. And it's one thing to recognise the normal, but then you need to recognise what's abnormal and then what to do about it. And I think that was again highlighted in I know we talked about this the other day, a coroner's case where a client was an NDIS client who had some support workers looking after him overnight, and he had had a fall in the bathroom on the evening shift. They put him to bed without doing any kind of assessment, not a formal assessment. He complained of some leg pain. They had a look at his leg and said, it looks fine to us. In the morning, when they went back to check him again, he was very unwell, and they called an ambulance, and he'd actually fractured his femur and had bled out into his femur, into his thigh all night. And when he got to hospital, he died of hypovolemic shock. I mean, that's just one simple example of how not having people with the right skills, knowledge and training can impact someone's life, and that cost that man his life. Had he been appropriately assessed post a fall like a nurse would have on the night before, he wouldn't have died.
Yeah.
Not from hypovolemic shock the next day anyway.
Yeah. Now look, this is how significant this is what we're talking about today. And the NDIS is almost treating some of their participants as second-class participants, quite frankly, because the reality also is if the clients that need, whether it's ventilation, tracheostomy, whether they need medication management, whether they need catheter care, PEG tube management, whatever it is, if they do go back to hospital, there's no support worker looking after them. There's registered nurses looking after them. So what is the difference in the community? Because the level of care is not changing for these participants,
No. And look, I think it's really important to highlight that there's a lot of really good support workers out there who do some really fantastic work within their scope of practice. And it's, what we're highlighting is that there is definitely a space for support workers, and we know that we've got a nursing shortage and we have to work within that as well. But giving support workers, high intensity tasks, we're not just doing tasks when we're looking after someone with high intensity needs. Suctioning a tracheostomy isn't just about the task, or even something as simple as, just doing a turn on that person. It's not when it's a nurse, we're not just turning the client. Every interaction with the client is an opportunity for an assessment. And whether that be informal or formal, we're always looking, what's their colour of their skin like? What's the colour of their nails and lips like? Do they look like they're breathing okay? Have they got any pressure areas when we're turning? Is there any red areas that need intervention? It's constantly assessing it. We're not just doing tasks. And I think it's really disrespectful to the nursing profession to insinuate that our work is just task-based, because it's not. It's comprehensive and it's holistic. And we're always looking at everything, even when we're doing something as simple as suctioning a trachea.
Yeah.
And I think that you can't teach that to someone on an online course and a basic training without any education in pathophysiology and anatomy. You just can't. Otherwise, why would we bother to have all of this education training for registered nurses?
That's right. That's right. And, just to highlight here once again, the NDIS is basically asking CCRNs, critical care registered nurses, to delegate to support workers. They're not even asking us to delegate to a general registered nurse. Even that we couldn't do without them having done some 2 years in ICU. So we're missing, we're basically falling from sky high all the way down to bottom without any checks and balances here, right?
Yep.
It is absolutely dangerous. And like I said, a word to the NDIS here, the NDIS is treating some of their participants as almost second-class participants, saying, well, if you were in hospital, you get gold standard care, but if you're going into the community, you don't get gold standard care.
No.
And that is just wrong. The other thing that I want to mention on that is it's also not evidence-based. When you look on our website at intensivecarehome.com, there is a section, the mechanical home ventilation guidelines. They are actually evidence-based. It's a result of nearly 25 years of intensive care at home nursing in Germany, but also we've provided enough evidence here in Australia now that this model of care is clearly working, and that exclusively ICU nurses with a minimum of 2 years intensive care experience, ideally with a postgraduate critical care qualification, are safe to keep ventilated/tracheostomy clients at home safely and predictably. So there's evidence, there's research has gone into that. Where's the research for support workers? Well, the research for support workers is people have died.
Yeah. And that's the thing, in investigating this delegated model of care, I couldn't actually find any evidence that this is a safe model of care. Whereas we know that, having a critical care RN looking after a ventilated client in the home, they're not waiting until things go wrong to call for help. They're always assessing, and they're picking things up early before they become a crisis point. So that's how we're able to keep those clients at home safely, is that we're always looking at, what's trending in the wrong direction, what needs addressing right now before it gets to the point where the client is unwell and needs to be back in hospital, or you're needing to be calling an ambulance to manage something that's an emergency. Because with the right care, it often never gets to that point, because we're constantly intervening, because we know how to treat those things as they arise, not wait till the client's clearly unwell.
Yeah. And I also want to highlight here, I know you've heard me saying this before, providing care in the community for our clients with support workers is like flying the airplane with a cabin crew, but not with the pilot. Yes. That's the best comparison that I've come up with.
Absolutely.
There's another thing in the community, Kristi, that I've picked up, and I'm sure you've picked it up too. There are some clients in the community, they don't want extensive monitoring, right? Which is something we need to respect. Now, as critical care nurses, I argue, okay, we would prefer monitor, but if that's a client's preference, we respect that, of course. But that's also where critical thinking comes in, and where your ICU nursing skills come in. What else do I need to look for when I don't have a monitor?
Well, that's just it. And that's what I mean when, all those opportunities, all those interactions are an opportunity for an assessment. And is that we often pick things up before the numbers change on the monitor. And I'm sure you've seen, and I've seen, Patrik, where we see somebody deteriorating before the SATs ever drop. And we know that, their breathing doesn't look right. Their colour of their nail beds might have changed and be a little dusky. Or it's all those things. We don't have to have a monitor on all the time. And often we're checking, saturations after we've seen a clinical change. because we are picking up on those subtle changes that occur because we know what we're looking for. Whereas, you know, there a lot of the time with support workers, they might put the monitoring on, but they don't understand what they're seeing. So, you know, unless they understand what those physiological changes mean, and just because somebody's blood pressure remains within a normal range, but it might have dropped from, you know, 140 to 105, and they're like, oh, 105 is still okay. Well, it's not if their normal blood pressure is normally 140 and they're showing other signs of being unwell, like their temperature might be going up or their SATs might be dropping there, especially rest rate, you know, which is something that I don't think most support workers would understand the significance of. And I argue that some nurses don't understand the significance of rest rate, but it's one of the key indicators for clinical deterioration. And, you know, we have sets of national standards that we work by, you know, that have clear guidelines on things like responding to deterioration and, you know, making sure that the care that we're providing is high quality and safe. But those standards don't apply. You know, they still apply, but they're not as understood by the support workers because it's not part of their training, whereas it is part of our training. We have a code of conduct that we have to practice by. We have professional standards that we have to follow as part of our registration. And if we don't follow them and we breach them, we lose our job, we lose our career, we lose our registration. There's no oversight with support workers. It's not the same level of oversight. It's not the same level of education.
Yeah. Another thing, Kristi, that I found out in the last few weeks, and I haven't actually shared with you, I am talking to NDIS accreditation bodies, right? They are well aware of the issue, right? So my understanding from some of these accreditation bodies is that they are now stopping to accredit support worker agencies and tick them off for ventilation, tracheostomy, medication management. They stop accrediting them for it, which is a good sign to me, which means, you know, it's not only up to the NDIS to say, you provide us, I want you to provide this, right? Now there's also hopefully another level of oversight coming in from the accreditation bodies where an RN just says, an RN being employed by an accrediting body saying, hang on a second, this is just wrong. We can't go down that track unless you have X number of nurses in your organization that are critical care nurses. You can't provide this service. But it also sounds to me like in the past, many organizations have been accredited in the support worker agency world. I don't know how. Right? Again, I don't know what the exact regulations there are from the NDIS, but hopefully there is more oversight coming in from accrediting bodies as well.
I hope so. And I hope a lot of lessons have been learned out of the Aged Care Royal Commission, because I think we went down this track with aged care as well. You know, these are complex clients who are probably some of the sickest people most of us will ever look after is our elderly population. They've got, you know, not only the changes that come with aging, but they've got a lot of comorbidities. They're often frail. Then you add in things like, you know, dementia and Alzheimer's and all of those things. And for a long time, we took the nursing out of nursing homes. And it took a Royal Commission to highlight the problems that created and the poor care, poor outcomes, you know, the people dying in pain, lack of palliative care, you know, falls prevention, treatment after falls. There were so many problems, that the Royal Commission's findings were to put nurses back into aged care. So we really have to repeat the mistakes that we made in aged care to then say, we're doing the same to people with disabilities, because a lot of them have got overlap with severe health issues, whether that be from head injuries or, you know, cerebral palsy, or there's a multitude of things where health overlaps with disability. And I feel like we're heading down the same track, is that, you know, we're putting untrained workers or poorly trained or, you know, suboptimally trained people to predominantly care for these people. We're just going to end up in the same boat, because these are people with higher intensity needs. They've got complex needs. Health overlaps with disability. It just does. You can't separate the two. And you can't then just say, well, just because they're under disability services, that they don't then need a nurse, because they do. Some of them do. Not everybody does, but some of them do. And where they do, and a nurse has decided, because that's who is in charge of responsible for the delegation, if a nurse has decided the only safe delegation is to another nurse, then I don't understand how the NDIS can overrule that, because who's deciding that? Based on what? Because we're providing evidence-based, rationales for our decision to have a nurse, but they're not providing the same level of evidence when they're saying that they don't need a nurse.
Yeah. And what I also want to say on that note is, for anyone watching this that might be in a similar situation with a family member, or you might be watching this and you are yourself in a situation like that, there's never been an issue with funding from the NDIS with the right evidence, but also with the right NDIS support coordinator. So your NDIS support coordinator will make all the difference by gathering the right evidence, by asking the professionals, what is required to get the right level of funding for a particular client or for your situation. So I also want to, this is not a rant on, what isn't working. It's also to highlight what is working, because
yes, absolutely,
clearly working, you can, you can look up our job ads on Seek. We are employing critical care nurses for the type of work that we are setting out, that we say we do, which is intensive care at home. But Kristi, where can you see this going in the long run? You've already alluded to, we don't want to go down the track of another Royal Commission, because the warning signs are already there.
Look, I think they are, and I think that there's already been a lot of issues with, clients. It's sad that it takes a client's death to make the media, and a lot of them don't, because a lot of people with severe disabilities, when they do pass away and there may have been complications, they're often not highlighted to, the coroner or, through any kind of reporting body, because people go, well, they were deteriorating and they were going to die anyway. And I think that's a lot of the time, I certainly know of cases where that's happened, where they've said, oh, well, they were deteriorating anyway, so this is just part of the journey, whereas they haven't really highlighted, well, could that have been prevented if they'd have had better care or more involvement with nursing care? And I worry that we're heading down that same path of that there's just going to be more and more people who have serious complications because they're not being provided with the right level of care, because clients have either been misled to think that they're not going to get nursing care funded, or they haven't got the right advocates, who are advocating on their behalf to say, well, actually, you can get funding for nursing care, and you just need the right evidence to say that, and the right rationale to say that this is why you need it. And we're certainly not advocating for nurses for everybody, because not everybody needs it, but where they do, and there's evidence that it makes a difference to their life and their goals, because that's what's important is, people with disabilities have goals for their life, and if having nursing care involvement means that they get to fulfill those goals and make their life better and, improve their health and well-being, then that's what we should be advocating for. And I worry that we're going to head down the same path where we have, these people dying unnecessarily or having serious consequences unnecessarily, and that we end up in another Royal Commission when we know that this is happening, and we know that there's, it really is not a hard fix.
No, it's not a hard fix. It's definitely not a hard fix. No. And we need also, on a much bigger picture level, we need to move more and more care of people whenever appropriate into the community.
Yes.
To improve their quality of life, but also take the pressure off the hospitals. It's not only about what level of care is someone getting in the community. It's also about looking at the bigger picture. I mean, hospitals, there's backlogs everywhere. There's bed blocks everywhere.
Yeah.
It's from my perspective, we are providing a win-win situation here by taking people home, taking pressure off the health system, and more importantly, improving the quality of life for the people.
Oh, 100%. And, nobody wants to be in hospital. And when people with disabilities are in hospital, they miss out on all of the community engagement and all of the things that make their life more fulfilling. So we want to keep them at home as much as we can, because that's their goal as well. And providing them with the right care means that they have all of those opportunities, which they don't get once they're in hospital, just through the nature of why they're there.
Absolutely. Kristi, can you talk, lastly, the other thing we haven't touched on in much detail is, can you talk a little bit about APRA and our, obviously it's RN, our APRA guidelines, and how do they impact on or interact with what we've been talking about today?
Yeah, look, I think that's really important, is that as registered nurses, we are accountable to APRA and the Nurses Board. They are who govern our registration and set the standards for our professional care that we deliver. And every year when we redo our registration and we tick all those boxes and, sign off at the bottom that we will, maintain our CPD and that we'll practice in accordance with the Code of Conduct and the International Code of Ethics and the professional standards for whether you're an RN or an EN or a midwife, that we understand what we're actually signing and that we have read those documents, because they do form the basis for our practice. And they are, a lot of them are guidelines and they're not specific to everybody's role, but they are involved in everybody's role, no matter what level of education you've got, whether you're a RUSON or a grad or, you've got 30 years of experience. They are appropriate and applicable to every level of nursing care in every environment that we work in, whether it be community in somebody's home, whether it be in a hospital, aged care, it doesn't matter. We have to make sure that we're practicing in accordance with those guidelines.
Yeah.
And so the delegation is part of that as well. And just understanding what you're actually, what governs our practice is really important.
Yeah, absolutely. And that's also where insurance is coming in, that if we do
100%.
go against our APRA guidelines and we do delegate against APRA guidelines, no one is going to insure us as part of our professional indemnity.
Well, that's right. And I mean, you risk being reported if you're breaching those guidelines, those codes of conduct and the professional standards. You risk being reported to APRA. And if you have done the wrong thing, then you will face consequences. And one of those consequences can be that you end up in VCAT having to argue your case and potentially facing, your registration being suspended or removed. So, and it certainly happened before.
Yeah, absolutely. And Kristi, what would be your advice if let's just say an NDIS support coordinator comes to a provider and says, hey, you've got registered nurses on your books. Can your registered nurses train those support workers on ventilation, tracheostomy? Can you show them the hands-on stuff? What would be your advice to an RN or a CCRN in a situation like that?
I would be looking really seriously at reading the delegation guidelines for starters. They're really clearly outlined on the Nurses Board website. There's also a position statement from the ANMF on delegation, which explains it quite clearly in layman's terms, which I think is quite good if you're not, used to reading those other documents, which can sometimes be a little wordy. But it is really on you to understand what that delegation requirements are. And if you don't feel like that is a safe thing and that it's within your own scope of practice or the person that you're potentially having to train, and most nurses are not educators, unless you've got a qualification to educate people, you really shouldn't be put in that position where you're having to train someone without understanding what you're doing and what responsibility falls back on you. And my advice would be to, if that's the position that you're finding yourself in, is to seek some legal advice. Everybody is entitled to that through their professional indemnity insurance, which every registered nurse has to have. And to really clarify what that role is for you and whether or not it's appropriate for you to be doing that. And if you don't feel like it is, you need to speak up, because it's your registration on the line. It's your career that you've worked hard for. Why would you risk that for anybody?
Yeah, absolutely. No, thank you. Well, Kristi, thank you so much for sharing all your wisdom and your insights there, and also thank you for all the work that you've done for us so far.
Thanks for having me.
Kristi, where can people find you if they want to engage you or continue the conversation on another level? Where can people find you?
Yeah, sure. So I've got a website. It's at Unity LNC, for Unity Legal Nurse Consulting. So unitylnc.com.au. And there's a contact me button on there, or my phone number's there if anyone wants to have a chat about it or wants to contact me through the website.
That's great. And we'll put a link in the transcript here. Okay. Well, thank you again, Kristi. We'll wrap this up here. Now, if you need help with intensive care at home, go to intensivecareathome.com and contact us on one of the numbers on the top of our website, or send us an email to info@intensivecareathome.com. We also provide level 2 and level 3 NDIS support coordination. We do provide specialist NDIS nursing assessments. We do currently have jobs for CCRNs, predominantly in Melbourne, Sydney, Brisbane, but also in Albury, Wodonga, Port Macquarie, Bendigo, and in Warragul in Victoria. If you are an intensive care specialist watching this and you have bed blocks in your ICU, I would encourage you to reach out to us. The same if you're a hospital executive watching this. You should contact us to help you eliminate your bed blocks. We have also sent our critical care nurses to provide an emergency department bypass service. So there's a number of services we can help you with. Thanks again, Kristi, for coming on to this podcast. If you like my videos, subscribe to my YouTube channel, click the like button, click the notification bell, and share the video with your friends and families. Thanks again for watching. This is Patrik Hutzel from intensivecareathome.com. And thanks again, Kristi. Take care.
Thank you.